Excellent. So good afternoon, everybody. And for those of you joining us, I see we have 5 really beautiful people. If you're able to turn your camera on, I have heard from our presenters in the past, it does help them to get a reaction from your facial expressions. If you're able to, please do turn on your camera. It makes it better for our illustrious presenter, who I will interview. And as I said, this is sort of the 5-cent introduction for Dr. Quesada because she has a very lengthy and really impressive resume. She has been at UMB, we were just discussing, for 20 years and has experienced it from a number of different positions on campus, starting as a student. And then you were a post-grad here, you did that. And then you had a fellowship here as well. And then now leading the admissions process for the School of Medicine here, which is super exciting. So you have a number of titles. I think the most important one is assistant or associate professor, which is fabulous. But you also have associate dean for medical school admissions, which was I referenced, and also associate dean for faculty diversity and inclusion. And then there was a whole bunch of other associate titles that were very impressive, but the one I'll mention here is course director for medical Spanish. I think that leads us directly into the topic of the day, which is about effectively working and appropriately working, I would say, with interpreters. So I will just turn this over to you, Dr. Quesada. Thank you for being with us today. And as a reminder to everybody, this is being recorded, and our intention is to put it up on the Center for Global Education's website so that people who would like to tune in later will be able to benefit from your expertise. So without further ado, I'm going to make one more thing. Lauren, any housekeeping things that need to be mentioned, or no, we're good? Great. Dr. Quesada, over to you.
All right. Well, thank you very much first to Bonnie for the invitation to present today. Definitely thanks to all of you who are here with us today, and for anyone who's going to be watching this later on. Thanks also for the warm welcome and introduction. It's definitely my pleasure to talk about a topic that is very near and dear to my heart, which is about working with interpreters. I'm going to go ahead and share my screen now. And I guess I'll get into some of the details later about why this is near and dear to my heart. But I think actually it should be near and dear important to all of us, right? This is really, really pertinent and relevant to all of us in all of our work. And honestly, here in the area where we live, work, but also even if we move really anywhere in our country, I think this is really, really important and relevant. So in the time that we have together, I have a few objectives I hope that I meet. The one thing is to tease out the difference between interpreter and translator. They're often used interchangeably and they're not the same thing. And then talk about sort of the why, really sort of the justification for why interpreter services are so valuable to have and important to utilize as a resource in the multiple ways that we care for and service and serve this community. I will talk a little bit about why this is personally an important topic for me and why I feel positioned to be able to provide some insight on this topic. And then we'll go into some highlights on really thinking through the process of when we should be reaching out for help from interpreter services, and also how we as providers who are doing that, how can we best sort of cultivate an environment that makes that a very smooth process. So first and foremost, teasing out the difference here. And so I guess I'll also jump in as to why this is a personal topic for me. My father is a translator, and he has, he's actually been doing this for, I guess, more than 60 years now. And he mostly is English, Spanish, but he speaks other languages, has also translated into French and Portuguese. And on a few rare occasions, he would get invited to be an interpreter at an international conference. And so he always was very, very basically drilled into me that it's very important to be clear that these are wildly different jobs and skill sets. And as a translator, he is a force of nature and he's like extremely talented. As an interpreter, he didn't feel so good. It is basically the difference then being that the translator is really translating the written words, so written documents, whereas an interpreter is in real time interpreting the spoken word. Now, again, you might see these things used interchangeably, but today I'm really going to be talking about interpreter services and that spoken language interpretation. I will say make a point for translation at the end as well, though. So let's jump right into why. Why is this important? Why are we talking about this? And why should we be advocating for more use of interpreter services? I think we all know, it's no secret, that the US is diverse and it is continuously becoming more diverse, which is a wonderful thing. I remember when this census report first came out, and I want to say it was around maybe 2014, 2015, that there was this projection that by 2020, which obviously is already behind us now, that the majority of all children in our country would be of what was at the time basically a minoritized group, and that by 2044, so in the not too distant future, the majority of all people in this country of Americans will also be what are typically considered minority groups. So again, rapidly increasingly more diverse nation that we live in. And that also means that we should be thinking about the possibility of more languages that might be spoken in homes and outside of that. And the census does also collect language information and asks what are the languages spoken at home. And we are seeing an increase in the diversity of languages spoken in the US as well, commensurate with the increase in racial and ethnic diversity. This is from the Pew Research Center. This is 2018 data. Again, looking at the whole country, you can see what are some of the more common languages other than English. I mean, English, of course, is there, but you can see this is among folks who are born outside of the US. So among immigrants, these are some of the more common languages that are spoken. And specifically for Maryland, and this is not terribly recent data. I wasn't able to find something more new than this. I'm hoping that something will come out now 10 years later, because the most recent was 2012 here. But you can see that among those who did not only speak English, these are some of the languages that are more commonly spoken and in the home in Maryland. And again, even though this is from 2012, I know that the top 4 languages that come up here, which are Spanish, they're called African language, more specifically, I've seen West African languages, French and Chinese are currently the top 4 most commonly spoken languages in Maryland. What I think is interesting to note, though, if you'll go back to this pie chart on the left, then you can see that among those who don't only speak English, a majority of that group also speaks another language and speaks English very well. So there are very many multilingual individuals in Maryland, and then also still a significant proportion that don't feel like they speak English very well, which could mean in both of those categories. There's a lot of personal perception of how well or not well you think you speak, but generally speaking, I think it's important to also remember that many patients are bilingual or multilingual. This is also looking again back at the US just to see the growth of native speakers. If we were to look at Spanish, I mean, you can see basically a quadrupling from 1980 to 2015 in the number of Spanish speaking individuals in the country. So I guess it's just to make the point that, for one thing, this is relevant for so many people, for a growing number of individuals in the communities that we serve. Another reason to think about this, though, is because we know that there are health disparities. As a health professional, this is an area of particular interest to me. And across multiple different disease processes, there have been well-documented health disparities. Of course, COVID-19 was a wonderful, or terrible, I should say, example of that playing out, honestly, in real time for all the world to see, right? Once we actually started tracking those numbers and looking to see if we could identify a difference across race and ethnicity, it was pretty clear that there are communities that were placed in vulnerable positions and due to social situations were much more likely to contract COVID-19 and potentially more likely to die from COVID-19. So another healthcare disparity as a gastroenterologist that I pay attention to is colorectal cancer. This demonstrates, as of, again, 10 years ago in 2012, because of the increase in the use of colon cancer screening, which is predominantly colonoscopy, but there are also additional tests like the FIT test, which is a stool test that looks is a DNA-based test. You can see, if you look at the solid lines, which are for female or male white patients, that you can see that the trend shows a decrease over time, which is associated with improved or increased use of screening interventions to be able to prevent colon cancer before it even starts. Unfortunately, in that same time window, you see that the incidence of colorectal cancer and advanced stages of colorectal cancer actually increased for the Hispanic community. And in fact, with the pandemic, that actually shut down elective procedures like many screening procedures to prevent cancer, we already are seeing a backlog of availability and access to these services and projections for, unfortunately, increased rates of diagnosis of cancers, including colon cancer, and expectations that patients are being, and actually already in the last year have been seeing patients being diagnosed at more advanced stages of cancer, which is just awful, especially when you think about the fact that colon cancer is a very preventable disease. So thinking about how this also is probably exacerbating even further the disparity for our patients who are already suffering from the healthcare disparities. So why do disparities occur? I think it's important to start off by saying that genetic factors do not explain racial or ethnic health disparities. This is really at its core is because we define race socially, not genetically or biologically. So when we see these differences in health outcomes by race and by ethnicity, in fact, what we're identifying are social factors that are driving those differences. And so this is where social determinants of health are so important. And you think about access to care, which of course could include any of these things I'm listed. It's a very long list, right, of potential determinants, but including insurance status, occupational hazards, access to healthy food, but language accessibility as well. And if you think about coming from the system level factors, how accessible are we from a language perspective for diverse communities? And then there are also patient level factors. Again, in terms of accessing care, the patient's language abilities may potentially pose a barrier. Or especially for our patients who may be undocumented, there may be some anxiety, basically, or hesitation with engaging with the healthcare system, really with any system. And if we are, for example, seen as but if we're a public affiliated with the government, or is there potentially going to be, or is it going to be a safe basically option for them to seek out healthcare? And then certainly cost can be very prohibitive for our uninsured, underinsured patients. And even actually, I have very reasonably insured patients who are facing, unfortunately, terrible costs because of some of the biologic medications that are exceedingly expensive and copays, et cetera. So unfortunately, there are a lot of reasons why we might see disparities that are, again, driven really by some social factors. And if we think also too about both the provider and health system factors, we have to also think and recognize, be aware of our own potential biases that we're bringing into the interaction, whether they are conscious or unconscious, and also time, which is, you know, it feels like it's a provider decision, but this is also a system level issue, that the time for interactions can often be very, very brief, and certainly not long enough that to really fully allow a provider and a client or patient to be able to have a meaningful interaction. And particularly, I think this comes into play when we're thinking about including interpreter services. You will need to think about the fact that this is going to factor in some additional time here because of the need to have things spoken in more than one language. But one thing that I think is really reassuring and affirming in why it's not only important to do, but that we really can expect that we are doing a good thing, we're doing the right thing when we are using interpreter services, is that physician-patient concordance is tremendously powerful. And there can be concordance on different levels, right? There can be gender concordance, there can be racial or ethnic concordance, there can be language concordance, and there are many studies that have been done to measure that and to measure the impact of either concordance or discordance across these different identities and factors. And over and again, what seems the common theme is essentially that when there is concordance on any of these levels, and ideally on all of them, that there is just a tremendous increase in patient satisfaction. And the patient can really feel that they've received the highest quality of care when all of these things are aligned, which of course for me, as someone who has a role in admissions, is also a really strong motivator about diversifying the physician workforce through my role at the School of Medicine. But what I think, again, is really important and interesting is even in those studies, when they compared the impact and the effect of racial and ethnic concordance against language concordance, while both were important and meaningful, the language concordance actually was the most important, actually was a little more meaningful and powerful. Patients who speak another language and can find a provider, or clients that can find a provider that speaks the same language as they do, it is transformative, right? It is exceedingly powerful to be able to form a bond and a connection when you're literally speaking the same language. And you can think about even when, let's say for those of us who are comfortable speaking in English, and you're working with somebody who also speaks English, even then, right, there are going to be some misunderstandings, miscommunication, hesitation, et cetera. Think about now adding that additional layer of not speaking the same language and somebody sort of trying to fumble through without having real proficiency in the language, just how much more you're missing out, right, on really having a meaningful exchange. This is just this was a larger review that was looking at these different concordance studies. They actually compared on terms of racial concordance, 13 studies, which found that when there was racial and ethnic concordance, again, the patients perceived a higher quality of care. There were actually longer visit times and also better communication, both on terms of the patient and the provider, and just increased satisfaction. And then with language concordance, there were 18 studies. They actually were able to show that some outcome results that I think are really important: decreased emergency room visits, probably because maybe there was an opportunity to intervene before you get to that stage, improved adherence to appointments, and also the decreased risk of misunderstanding some of the instructions and recommendations, labels, et cetera, which is obviously a huge safety issue as well to think about. And this study is the last one I'll mention, but I think it's really a great one to include because they also looked not only at the provider, but also at all of the staff involved in the office or suite where the client or patient in this case is presenting. And just when even the all the staff in the office also have language concordance, again, tremendous value to the patient. And I think probably the most powerful one being that they were less likely to feel that they were being treated unfairly. They felt more respect and that they were being treated fairly when there was language concordance. The other reason that we should do this, and so why, we are a publicly funded institution, and therefore Title VI of the Civil Rights Act matters to us as much as it should, or more so even than some private institutions, that no person in the US on the grounds of race, color, national origin should be excluded from participation in or denied benefits of or subject to discrimination of activity for receiving federal financial assistance. And when we interpret this, the Supreme Court has essentially treated discrimination based on language as being equivalent to discrimination based on national origin. So if we are not providing interpreter and translational services, then we are essentially discriminating based on language, and we are not aligned with our own Civil Rights Act. So it's the right thing to do, and it is also the law. So why me? Why do I like talking about this? It's part of it is my dad, but the other part, and I think maybe he's still, is another reason why this is relevant and he's still part of this story, is before I went to medical school, I worked for a little over a year as an English-Spanish medical interpreter at a hospital in New York, where there is a huge Spanish-speaking population. And I underwent a very rigorous training to do simultaneous interpretation, which is one strategy or one method of interpreting, which basically means that while one person is speaking, I'm literally talking over them in the other language, and then the other individual responds. And again, I'm listening and talking at the same time. It takes a lot of practice and training. And more often, I think what we see is what's called consecutive interpretation, which is where, say, you say what you want to say, you pause, you let the interpreter interject and interpret what you said, and then the other individual can speak as well. Bonnie, I see your hand is up.
I didn't want to just interrupt, but I find that fascinating that you did that. And it's my understanding that simultaneous interpretation is far harder than the consecutive, because you don't have time to think about what you heard, mentally put it into the other language and say it. So my question is, did you then become a doctor because you thought it would be easier?
That is a good question. No, I actually had already decided, and I was already pretty clear in my pursuit to go to medical school at that point. In fact, that was part of the reason why I got this job, was because I knew it was going to give me very valuable exposure to the clinical world and to the interaction between physicians and patients. But I also could appreciate in that moment how much I was learning that I was going to take with me into medicine. I had to learn so much medical terminology, and even just, again, observing the interaction and that bond that was there, even with the language barrier, was really, really meaningful for me. And I think a lot of people think that simultaneous interpretation is harder to do. That said, I think once you get used to doing it, I always then preferred that. I felt it was easier to do that because you can just keep going. Whereas when there's consecutive, sometimes people talk for a really long time. And as the interpreter, you're trying to remember all the things that they said. And then when they finally stop, you're like, ooh, okay, let's see if I remember everything that just happened. You don't have to do that. When you're doing simultaneous interpreter, there's no remembering and that was the other thing too that I think was really valuable. And I still think with consecutive, one can and should do this, but that as an interpreter, we're not summarizing, we don't want to paraphrase or change anything. We really want it to just be purely, we say exactly what was said. And so I think it's actually easier to do that when you're doing it simultaneous, but it does take a lot of practice. So I underwent the training program. It was at Columbia, and then I should also, of course, as a provider myself, I also have certainly worked with interpreters and needed them because, again, we're serving a diverse patient population. But much of what I'll say in the next few slides really is coming from the perspective of somebody who has been an interpreter and hopefully can be sort of insightful as we're thinking about how to work with interpreters. When I was undergoing the training, and maybe there are some folks on the call here who've also been an interpreter or worked with an interpreter in the past. I remember when I was undergoing my training, it was very, very, I think just instilled in us that we are the bridge, that we really are the enablers of the communication between the provider and the patient in this case, and your client. And that our goal, again, is to be exceedingly professional. We were all volunteers, and we were quite professional, to be timely, to be accurate. We were told that we should always introduce ourselves because it could be, maybe if one or the other individual didn't know that interpreter was coming, then somebody might make an incorrect assumption and think that I'm the sister or the friend that's there. So to just be very clear and transparent on what your role is and how this interaction is going to work. Usually I would introduce myself, say I'm a simultaneous medical interpreter, which means when you speak, I'll be speaking at the same time. So that people also otherwise know that they can keep talking while I'm talking, they don't have to stop. But ideally the interpreter will explain ahead of time what their method is, so you know what to expect and there can be a smooth process there. And we were always taught if there's a word that we don't know, and that could happen in either style, that you do what we call you throw the word, which basically just means that you're going to say the word in the language, in the other language basically, and then this triggers an interaction. So I'll explain, because it did happen to me and I had to use the technique once. For some reason, I had a brain fart and I couldn't remember the word spleen in Spanish. I just couldn't. It was actually an interaction between a surgeon and a patient. The patient was being explained what the surgical procedure that's being recommended. And it involved a different organ. I think it was actually a bowel surgery, but they also were talking about, while we're there, we will also remove the spleen. And so I'm like, y también vamos a quitar el spleen, because I couldn't, it just wasn't there. And so you just say spleen. And so then, of course, the patient said, ¿el qué? And I'm like, the what? And they're like, the spleen. I'm like, el spleen. I'm like, ¿y qué es eso? And what is that? Like, oh, the spleen is an organ that sits in the side of your body. Oh, okay. And then we keep going. So basically now we're explaining what the spleen is, the patient understands, oh, okay. And then we just kind of move through it. And that's something that I often teach my students in medical Spanish as well. Sometimes you just don't think of the word, and that's okay. Just kind of explain what the word is, talk around it. And sometimes that's even better than the actual term that you were going to use, right? So anyway, so also very important to interpret not only the words that are coming out, but to interpret a lot of nonverbal or unspoken content. So to interpret, for example, the emotion within which something is said. If the patient, for example, is like, no, I'm not just going to say no, I'll say no. You really want to emote the same level of intensity that the party is expressing, so that the words really come with all of the feeling that they should communicate. Also, there are sayings sometimes, or some cultural nuance with language that don't translate very well literally into another language. And so many interpreters are not only interpreting language, but they're all doing some culturally appropriate interpretation for you as well, either for the provider or for the client, to basically be able to understand what is the idea, the concept, the message, and then I'm going to make sure that that's clearly communicated. Those are the only times where maybe the words shouldn't line up exactly the same, because we want to make sure that the meaning is there. And then finally, the other thing that I was always told is be invisible. Like, this is not about you. This is about the patient or the client, and it's about the provider that needs your help. They both need your help. This is about them being able to talk to each other and talk together. It should be as smooth as if you weren't there, as if they could speak the same language. And so I would always ask them, don't look at me, look at each other. As part of my introduction, I would say, I would like for you to look at each other when you're talking to each other. You don't need to look at me. And so that, again, trying to really truly foster that bond and that relationship, which is so much better, because if somebody's looking at the third person the whole time, it could really interrupt that communication. And ideally, if we're doing all those things, then what we're achieving is better rapport between the two individuals. I think better sense of trust. I especially think for the side of the patient or the client, they feel heard. They might be more likely to ask questions and feel more comfortable opening up and asking them. And again, we might see hopefully even some better outcomes for our patients and for our clients. So let's move on to the question of when. Sometimes I think that is a tricky question because of the fact that people are aware that we are a multilingual society, that there are many people who have studied other languages, have some level of proficiency, and so then are sort of like, well, do I really need one? I speak pretty good Mandarin, or I'm pretty good with French. Maybe I don't need an to work with an interpreter. It's going to be so much faster, you know, all those things. Or sometimes, you know, probably more often times, I already mentioned that most patients who speak a language other than English also speak some English, and it might be pretty good or it might be more minimal. And so you could also think about like, well, they understood everything. They knew, you know, they were able to set up the appointment. And so I think we're going to be okay here. So I think first and foremost, I think it's important to remember, even with the sort of civil rights mandate, that we should be providing linguistically appropriate services. At the end of the day, the person that determines whether or not the interpreters should be included is the patient or the client. It's our responsibility to offer these services, but we cannot impose or force someone to have an interpreter in the room. I can assure you that actually never, I don't think I've ever had a time where I offered that and the person said no when they really needed the interpreter service. The vast majority of the times, even my bilingual patients usually say yes. If I offer it, many of them will say, you know what, that would be good. That would be nice. They feel like again, it's more safe for them. There is a backup just in case they don't capture something. They can get some additional help with making sure they don't miss anything. Because why would you want to miss anything when you go see your provider? So just ask the patient. We should just be asking all of our patients and clients whether or not they would be interested in having interpreter services. They know, right, what their comfort level might be, and if that's something that they feel that they would benefit from. And ideally, this should be done very early on in the process, not when they're already there. That should happen before, at least in the outpatient setting, when the appointments are being made. That is really the time to make that offer and ask, so that then the scheduling can also, for the interpreter, can happen at that time. Most of the delay that is that people feel is prohibitive oftentimes to working with interpreters is more because we basically diagnosed the need or found the need for the interpreter too late in the process, where that we're all already sitting there and waits, and now we're sort of waiting and like, well, I guess I'm going to go see someone else while I'm waiting for the interpreter to get here. We can avoid all of that if we plan ahead. Bonnie, I see your hands up again.
I just wanted to make a mention of the comment that that Marcella shared. I don't know if you wanted to share it yourself, Marcella. It's very relevant right here.
Oh, sure. It was just that I'm a nurse. I'm in the School of Nursing, and I've just had patients before who've been bilingual and maybe can speak enough English conversationally or like to get by in the day-to-day. But when it comes down to reading either reading an information pack, like a emergency use authorization or something like that, or especially discussing the more complex issues that might come up in healthcare, that they'd prefer to speak in their native language. A specific example is I give monoclonal antibody treatments to COVID positive patients. And when they come in speaking Spanish, often, yes, we can have a minimal conversation or I can assess if they're in pain or not, but they want the emergency use authorization in Spanish. So I'll provide that.
I think that's a wonderful point. And it actually is very, I think very well aligned with the teaching point that I often give to my students in medical Spanish, which is that you are absolutely 100% there to provide that additional support, to help make sure that their questions are answered, et cetera. But then when it comes to like a consent form or sometimes some of these more legal documents, we really should be, again, bringing our interpreter services there to make sure that everything is done at a professional level and legally sound as well. So thank you for that comment. I also saw in the chat, since I'm sorry, I didn't mean to be ignoring the chat. I was so like,
No, and I'm happy to add those to the questions and whatnot as you go. Would you prefer to do questions as we go along, or would you like to just wait till the end and then we can use a little discussion? I don't know how much time.
Yeah.
We've got
Well,
left.
how about I'll just answer the ones that I see here, and then maybe we can hold off until the end for the remainder of the questions. So I saw one question that asked if insurance pays for this, and yes, it does. And one other new thing since I think the last time I gave this talk, which is super exciting, is with the use of telehealth. And we have teleport in Epic. There is now an icon where you can automatically click that and say, I need an interpreter. And so just like we're doing over Zoom, there can be 3 folks on the screen and you have the interpreter there in real time that can interpret an encounter. I'm actually really proud of our medical system at University of Maryland for thinking about that and including that. So it's ready to rock and roll. It's already available. So people should know that too. And then what is my method of getting feedback from the encounter regarding full understanding of the doctor and or patient, or is it assumed at the end of the encounter that everyone understood each other? Assume nothing. That is always the safer bet. I always, at the end of every encounter, ask 2 questions. Well, not only at the end of the encounter, at the end of every sort of spiel that I go through with providing recommendations. I definitely make sure, if I haven't already been doing this along the way, but certainly at the end, I was like, does that make sense? Do you have any questions? Is there anything that didn't make sense to you? And then at the end of the encounter, I usually ask again, do you have any other questions? Is there anything we haven't talked about that we should have talked about? And basically, again, did everything make sense? I also sometimes do the repeat back method. So at the end of, especially because sometimes, I treat inflammatory bowel disease, and sometimes there might be a very long list of recommendations. Maybe my patient needs a CAT scan. We're going to set them up for a colonoscopy, which means that you have to drink a prep. And then you also need to get labs done. And one of them is a stool study. I mean, it's a lot. And so, one of the things I do sometimes is also just ask the patient, okay, all right, I know I've said a lot of things. Tell me, what did you get out of that? What do you need to do next? And of course, I also give them written instructions that they can take with them, because it's a lot for anyone to remember. And when I can, I also make sure that those instructions are written in an appropriate language for the patient. So I'm not all knowing of all languages. I can do this with Spanish, but certainly if I have an interpreter working with me and my patient speaks a language that I don't, then I ask the interpreter, again, now we're doing a little translation here, and I'm asking them to help me make sure that we have those instructions written in both languages, right? Because we still need them written in English so that someone else can refer back to that and understand and see these were the instructions that were given to the patient, but also that it's in the available patient. Yeah, I do. Exactly. I'm doing that for all of my patients in English as well. All right, so let's keep going. I think we're doing great on time. And then this is, again, getting back to, as we as physicians, when do we might feel, are we okay? Maybe we can pull this off. I think generally if you're asking yourself the question, it probably should be, why don't you go ahead and just ask the interpreter to be there for you? And I've done that. Sometimes the interpreter arrived with the patient because the patient has learned that this is available and has learned to navigate that. And basically, I didn't know, and the patient also didn't know that I speak Spanish, so they arrive with a Spanish interpreter. And then I'm like, no, that's great, stay. And, we're going to talk, but you never know if there was still something that maybe, because of, even in Spanish, there are a lot of different sayings in different countries, and there could be different nuance. And we just want to make sure that we're all understanding each other. Never hurts to have a third brain in the room. And then, of course, the question, I think probably many people here have heard or seen this done before, where the patient does in fact come with a friend or family member, and the assumption either on the part of the provider or the patient or client is that this individual is not only there for moral support, but could also essentially be an interpreter. And again, it is the patient's decision who will be doing that. And so the patient may say, no, this is my cousin or my friend, my best friend, and I know they want the best for me, and they're bilingual and I trust them. I want them to be okay. That is their right? Their right to be able to choose that. But again, it's our responsibility just to make sure that we can offer that. And who knows, maybe the friend will be like, oh, thank goodness, because I don't want to have that responsibility. I just want to be here for moral support. And so, and again, there was always my favorite line, one of my favorite lines, one of my faculty, who's a colleague of mine now in gastroenterology, he used to always say, because we'd be going over the case afterward, and he'd be like, well, do they have a history of this or the other? And I'd be like, ooh, I'm not sure. And then he's like, well, when in doubt, ask the patient. Go back and ask them. They know the answer. And so same thing again, just ask the patient. And then this is a plug for translation services as well. There's a lot of paperwork. There are instructions that we're giving and education materials that we give to patients. There are translation services, and we are underutilizing them, just as we're underutilizing interpreter services. And we should be thinking about and asking if those materials that we're giving are in the ideal language for the clients and individuals that we're working with. I also think that they can be helpful in determining what your own, and strengthening your own vocabulary. When we had the COVID vaccination clinic at the campus center, we had on Saturdays a vaccine clinic primarily for Spanish-speaking individuals. And this was through a partnership with Casa de Maryland and the Esperanza Center. And it was wonderful that this was also equipped with the handout. It was the same handout that the patients were getting in English, but it was also a handout that was translated in Spanish because we were expecting Spanish-speaking patients that day. And we also had my medical students in medical Spanish that were there to help the patients navigate the clinic. So it really was, I think, a wonderful scenario. But the point of the story is, when I was reading the handouts that explained sort of the eligibility criteria and some of the risks of the vaccines in Spanish, I learned some great words, right? Some great words that I wouldn't have thought of on my own in that moment. And so having these tools are not only valuable for our patients, but they're valuable for us too. So in case anyone is interested, I wanted to just acknowledge again that we have these services available 24/7 at the medical center. There's some form. There's not always in person 24/7, but there's always at least over the telephone available. And as I mentioned, now I should add to this slide that even through our online portals, we also now have interpretation services that are available. And so when you do make that call and then include interpreter in the encounter, I think some probably basic things to think about, but maybe nice to be proactive about. Again, first and foremost is the more you've planned ahead for it, the better, the more smooth everything is going to go. And this can be done both for inpatients and outpatients. But the first step in doing that is that we're going to have to identify who are the individuals who will benefit from interpreter services. And if we just rely on who we think will benefit from it and only ask who we assume might benefit from it, what are the biases that are going to start coming out into play? But also, we're going to miss people. We're not asking everyone yet. And I think that that's really the standard that we need to get to, is really implementing an expectation, a protocol that all patients are offered and asked if they would like to have interpreter services. And again, I think it's pretty natural that for the outpatient scenario, you would do this initially at intake as you're scheduling the appointment, and then the scheduler can also help coordinate and make sure that an interpreter is available for that encounter. But even on the inpatient service, there are ways to do that. And I remember specifically for American Sign Language interpretation in the hospital, we also had that available. And this was not only pre-pandemic, I'm going to say this was easily 10 years ago, at least, that I remember I was serving on the oncology ward, and there was a patient who communicated through American Sign Language. And so what we had was basically a television on a cart on wheels that you could roll down the hall, and it was a video conference essentially with an interpreter that spoke, that could communicate with sign language. And so what I did was, okay, this is my patient. I need to see them every morning before rounds. And I coordinated with the interpreter. Could you be available every morning around 6:45? And again, I was giving myself extra time so that I could just, as if needed, have more time to spend with that patient before rounds. And it worked beautifully. I could plan everything else as needed around that time window, knowing that's my time I need to be in that patient's room, and I'm going to bring that cart over with me. And it was just so wonderful. It felt so good to know that you were providing this opportunity and appropriately giving your patient the ability to communicate all of their questions and have them answered. I think that for the in-person scenario, again, and if you can try, if you're planning ahead, then you're giving yourself an opportunity to factor in a little bit of additional time for that encounter. And you can also ask the interpreter, or make sure you're aware of what kind of method they use, whether it's simultaneous or consecutive. Then consecutive is definitely more common. But I prefer not to assume. I think if you ask, then again, you kind of know what to expect and how the flow of communication is going to happen. And just kind of let them do their thing. Let them come in, introduce themselves, explain how this is going to work. One other thing that they probably will say is, if I need to break interpretation, then I will say timeout, or I need to break. And sometimes you have to do that because you need to ask a clarifying question, either of the client or patient or of the providers. Like, I want to make sure I'm understanding what you're saying here. And you can ask, and you're like, all right, and then back and roll and keep going, keep looking at each other. I'm not here again. And let them, let the communication continue. So just some final points. We should be providing language appropriate services, which I think are very much intertwined and in harmony with the provision of culturally appropriate services. It is our duty, it's the right thing to do, and it's the law. And it means that we're giving better, higher quality care for our patients. And ultimately, I do believe that this does yield better outcomes for our patients. Our patients will be healthier and happier, and our clients will be healthier and happier and benefit more from your expertise, from your service. And we have them, again, we're underutilizing them. We should be calling them and including them in order to make sure everyone is benefiting from this amazing resource that we have. And I will end there. Thank you all for your wonderful attention. I'm going to stop sharing here and happy to take any additional or remaining questions.
Thank you so much, Dr. Quesada. That was really informative. And you know what I was thinking would be a nice addition to this, maybe, is if we could get like a case study, perhaps with volunteers, not an actual patient, but we could record an interaction using maybe your expertise in both as an interpreter as well as a provider, to be able to model what that looks like. I think that would be really helpful, because I've seen some pretty ugly, with just being present, to see some terrible attempts to communicate, and I can't even imagine it in a healthcare setting. So yeah. That might be our next way we rope you into to share your expertise. Let me just ask one question that I'm curious about, is the cultural aspects of interpreting. In other words, if someone says to me, or says to you as a provider or to the interpreter services, look, I'm a female, and in my culture, if I'm going to be talking about my female health issues, I don't want a man in the room with me. Is that something that you encounter, and how is that navigated?
Certainly that I have encountered that. And, I think that actually goes really actually broader and outside of the realm of just interpreter services, because that could happen even when the patient speaks the same language as the provider does. But I have seen that happen. And oftentimes what we try to do is accommodate the request of the patient. So if the patient is saying, I want gender concordance with my provider, and currently the person that I'm scheduled with is not, the same gender as me. And, of course, it's for a very, I think, appropriate reason. And so we make that accommodation in that moment as much as we can. I'm trying to think if there was ever a time where we couldn't. Fortunately, we have a pretty strong representation of women in my division, which is unusual because gastroenterology is a strongly male predominant specialty throughout the country. We're just a little bit unusual here at Maryland that we have a lot of women gastroenterologists. So we haven't had any problem in meeting that request, but it certainly has come up because, of course, as a gastroenterologist, we do have to not only talk about, but we have to examine our patients in very personal places and private areas that they very well may not be very comfortable having someone from a different gender examine.
Thank you. So I don't see any questions in the chat, but would anybody else like to make a comment or ask a question? Just unmute and plow ahead. No, everybody's going to be peaceful.
Well, I have a question. Sandra, thank you so much. That was so interesting, and so many elements to how important it is that I didn't realize. So I really appreciate your comments. I don't know if you know my background as a lawyer. One thing that really sticks out to me is, even in English, how oppressive the informed consent documents are, and we don't understand them or read them in English at all. And so I can imagine that must be quite a pressure on the interpreter, translator, to have to deal with those forms or be expected to translate them. So I guess more a comment or a question and what you think about that.
No, I completely agree with you. And frankly, that's why I'm grateful that we have interpreter services, because it's a lot. You know, when I have Spanish speaking patients, for example, that are coming in for colonoscopy, only because I've had so many, and because I have the spiel that I do in English, I practiced it so many times in Spanish that it finally felt easy to do. But it was quite a leap that I had to make, and it took practice to be able to do that. So doing that on the fly like that would have not been easy. And the only other thing I'll say is I remember while I was working as a medical interpreter, there was an opportunity, basically a request, could somebody, it was sort of a last minute request that somebody needed legal interpretation services, English, Spanish, and they wanted a simultaneous, and could any one of us go help out? And so mostly because I felt badly for that person that's about to go to court without interpretation services, I was like, well, nobody else seemed to be stepping up. And I'm like, I guess I'll try. And then I still remember I was sitting on the subway train on the way down towards the courthouse, and I was like, what did I get myself into? I don't know this stuff. I don't know this terminology. It's like a whole different, I was like desperate. I had done some research and was like desperately making notes about this word is this and whatever. And then I was like, oh my goodness, this is going to be tough. And again, it's a volunteer position, but I'm like, I hope it's going to be okay. And I walked in, and it turned out that the other party never showed up, so they had to reschedule the whole thing anyway. And I was like, whoo, I'm not gonna raise my hand again next time. I think it was not meant to be for me to be there. So it's, you know, yes, even an interpreter can find themselves, I think, it's sometimes really tough positions. But our the professional medical interpreters, I mean, that's their wheelhouse, right? And that's what they do. And this is why we need them, because that's even for someone who speaks the language fluently, and trying to translate or interpret a consent form is not going to be easy.
No.
I saw,
And
Remy, I think you had your hand up. Oh, I think
still
you're
muted.
muted.
Yeah, I have a question now. Okay, my question to you is, hi, thanks for the information. Is it a lot cheaper to have the three-way telephone rather than having a face-to-face interpretation? When you give the patient that, like the telephone, they have one receiver, then whoever is speaking with them will have the other receiver. Is it cheaper that way than have somebody actually come to see the patient in the room? Have we ever used that before?
Well, we have used the telephone. We do use the telephone interpreter services as well as in person. So both kinds are available. And I honestly don't know the answer about cost. I would imagine that probably per encounter, it is less expensive to do something over the phone than to have the person there in person. But I don't have any numbers off the top of my head to tell you. I would assume that there's like a contract with the interpreter company that then is providing these sort of 24-hour interpreters available over the phone.
Thank you.
Yep.
Great. Well, I can see we are past time, so we won't take any more time from you, Dr. Quesada, but thank you so much. And it's clear, I think you can see from the comments as well, that everybody felt this was a really worthwhile way to learn something over our lunch hour today. So thank you so much. And I have a ton more questions, but I'll just email them to you afterwards.
That sounds great. Thanks again for
Thank
having
you so
me.
much.
All right. Bye-bye.